Hello, everyone. My name is Dr. Hai Li from UC Davis. I will be presenting to you guys on thoracolumbar anatomy and trauma classification. Here's the outline for today's talk. We'll review the thoracic and lumbar bony anatomy, and then go over the discoligamentous structure of the thoracolumbar spine, and then talk about the spinal cord and nerve root anatomy. We'll also review some of the most commonly used classification for thoracolumbar spine trauma, and then end the day with some case example for us to review together. So here is the spine anatomy. When you look at the spine from a sagittal profile, here's the cervical spine, which normally is lordotic. Here's the thoracic spine, which is normally kyphotic from T1 to T12. And here's the lumbar spine, which is normally lordotic also from L1 to L5. In general, when you look at the cross section of the thoracic spine, here's the vertebral body, here's the spinal canal or vertebral foramen where the spinal cord goes down. Here's the transverse processes. Okay, on both sides, here's the spinous processes. And connecting the spinous process to the transverse process is the lamina. And then here's the pedicle connecting the posterior bony element to the vertebral body. And just to review again, on the axial view and the sagittal view, I think we reviewed all of that in detail already. But again, here's the body, here's the spinal canal, lamina, spinous process, transverse process, and it's important to take a look at also the articular processes, which include the superior and inferior articular processes. When you look at this from in the thoracic spine, what is unique about the thoracic spine? It articulates with the rib. Right, at a multiple level. Here's the rib facet here, as well as the rib facet here in the transverse process to articulate with the rib. But you know, when you look at the pedicle, and right next to the transverse processes and the pedicle is where the superior articular process is located. And this, in addition to the inferior articular process of the vertebral body from above, form the facet joint. And then here's the inferior articular process, which articulate with the superior articular process of the vertebra below. Okay. And then this is just to see how the bones articulate. Here's the first to 12 vertebral thoracic vertebrae, and here's the articulation here at each facet. Here's the superior articular process of T10. Articulating with the inferior articular process of T9, and this formed the foramen. So the foramen is really made up of the posterior vertebral body of T9, the disc of the T9-10, and then the facet structure, right? So when the nerve exit here, these are potential sites where the nerve can be impinged in the thoracic spine. Now let's review the lumbar spine anatomy. As I mentioned, it's normally lordotic, and when you look at the cross section of the lumbar spine, it essentially has similar structure, except that it doesn't have articulation for the ribs, right? So again, body, spinal canal or foramen, transverse processes bilaterally, lamina, spinous process, here are the pedicles, and then articular process. I think we're gonna see on the next slide a little bit more in detail, but all made up of very similar anatomy as the thoracic spine, except again, those rib articulation. As seen in the thoracic spine. Just to review again, here's the body, right? Here's the pedicle, spinous process, superior articular process, and then also inferior articular process right here. Okay, and then transverse process. So then when you look at the anatomy in the lumbar spine, which is probably more important in degenerative processes, here's the lumbar vertebrae, right? Here's the disc, intervertebral disc. Right, and here's the nerves, right, and here's the nerve exiting, and again, here's the articular process here that form the facet. So the facet is formed by the superior articular process of the lumbar vertebrae below and the inferior articular process of the lumbar vertebra above, and that form the neuroforamen for the nerve root to exit. And again, the foramen is surrounded by disc, posterior vertebral body, and the facet. Okay, and so this will be helpful when you plan for surgery. Now, it's also important and very important to also, in addition to the bone anatomy, to look and understand the different role of the discoligamentous anatomy. So for the disc, it's always going to consist of the outer fibrous layer and the inner more collagenous layer, okay? So the outer layer is the annulus fibrosus, the inner layer is the is made of type 2 hyaline structure, okay? And then in the front of the spine, there's a ligament called the anterior longitudinal ligament. And behind the posterior rotator body, there's a posterior longitudinal ligament. Now, when we hear a lot in the literature about the posterior ligamentous complex, and what that comprises, it comprises of 4 capsule ligamentous structure. It consists of the facet capsule, right? The ligamentum flavum with the yellow ligament, the interspinous ligament, and the supraspinous ligament. So when we say a PLC injury, it really describes an injury to one of the 4 ligamentous structure. And really to be unstable, you really have to typically injure all 4 component of the PLC. And we'll talk more about that. Now let's talk about some spinal cord and nerve root anatomy. All right, so in the thoracic spine, it's still spinal cord level, but typically the spinal cord end around L1 and L2. It typically form a narrow spinal cord structure called the conus medullaris, right? And then it gives off little strings of nerve root called the cauda equina, right? Similar to like a horse tail. And so hence the name, okay? So again, as you can see here, here's where the spinal cord ends at the conus medullaris, at the L1, L2 disc space. And then everything below that are nerve roots, okay? And that's the cauda equina. So when you injure anything above L1, then you can potentially injure the spinal cord, right? Anything at the L1, L2 level, you can injure the conus medullaris. And then anything below, you can injure the cauda equina. That's when you talk about cauda equina syndrome or nerve root symptoms. You can't injure your spinal cord if you have an injury below L1, right? Okay, and then when you talk more about nerve root anatomy, right? Here's the spinal cord again, right? Again, and the nerve root exit, right? The neuroforamen, right? They usually form a dorsal nerve root ganglion and leave ventral and dorsal roots here for each nerve roots or rootlets, okay? And then here's the cross-section anatomy. Here's the vertebra. Here's the spinal cord sitting in the spinal canal. And here is the ventral and dorsal nerve root, okay? Here's the dorsal root ganglion, and it's branching out to provide sensory and motor function here to your body. When you look at spinal cord anatomy, it's really important to understand also the cross-section of the spinal cord so that you can understand the different type of spinal cord injury. So I know it's a little bit complex on the slide, but several structures that you should really memorize is the, let's see here, spinal thalamic tract here, sitting in the front, okay? Here's and then the corticospinal tract here. Okay, as well as the dorsal white column. Okay, and then here's, so hopefully you can understand the different cross section of the spine anatomy to understand, when you have a anterior cord syndrome, central cord syndrome, right, or Brown-Séquard cord syndrome. What does that mean, and how does that really affect the patients on the exam and symptom wise? I think next we're going to talk a little bit about the different classification system for thoracolumbar trauma, traumatic injury of the spine. As you know, there's a long history of different classification systems, right? And we actually wrote on this, and I'm happy to share the PDF with you all. But the main focus today is to really talk about the TLICS system, as well as the Denis classification, which I think is really helpful to understand how to manage thoracolumbar spine anatomy. trauma. So when Denis was really the first person to, identify the spine into 3 separate columns, right? The anterior, middle, and then the posterior column. So according to Denis, the anterior column consists of anything anterior to the second half of the vertebral body. So that includes the ALL and the half of the vertebral body. And then the middle column is the rest of the vertebral body and the PLL, okay? And then the posterior column is anything from the PLL all the way back to the supraspinous ligament, okay? And so according to Denis, if you injure any 2 columns, right, that accounts for unstable, potentially unstable spine. And then Denis was also the first person to classify injury type into to 4 different classifications that we are commonly used now. And with each injury, it was determined by whether there was an injury to the anterior, middle, or posterior column. Okay, so for example, a compression injury, by definition, by Denis classification, is only a compression injury to the anterior column. All right, if you have injury to both the anterior and middle column through a compression mechanism, that by Denis classification is classified as a burst fracture. Then we hear a lot about the seatbelt type injury, which is a flexion distraction injury or chance fracture. That is associated with flexion of the anterior column, but distraction of the middle and posterior column. And then finally, fracture dislocation is a component of multiple different force and vectors in the anterior, middle, and posterior columns, including compression, rotation, and shear. So I think for Denis classification, just understand that the spine is divided into 3 columns, anterior, middle, and posterior column. And any combination of injury to both columns, so two of the 3 columns, can be potentially unstable. Now, the TLICS classification that was developed by multiple spine surgeons, especially those from Rothman, really look at the different injury of the thoracolumbar spine through 3 separate categories. They first look at the injury morphology, then the neurological status, and then the integrity of the posterior ligamentous complex. And then they assign different points to these different categories. And then the numbers to remember is that anything above or equal to 5, the general recommendation is to do surgery. Anything less than or equal to 3, the general recommendation is to treat the patient non-operatively. And then a score of 4 really can be either managed operatively or non-operatively. So for the injury morphology, if there's a compression fracture, it generally get 1 point. But if it's a burst fracture, you get 2 points, right? Because it's a little bit high energy mechanism. If there's a translation or rotational injury, then it's 3 points. And then if it's a flexion distraction injury, it's 4 points. And then neurological status, if the patient is intact, there's the 0 point assigned. If it's really just nerve root involvement, then they get 2 points. If it's the conus medullaris involvement or the spinal cord involvement that is complete, you get 2 points. Right? If it's incomplete, there's 3 points, right? And then if it's caudal equinus syndrome or involvement, you get 3 points, okay? And then integrity of the PLC, if it's intact based on imaging, then it's 0 point. If it's injured, you get 3 points. But if it's suspected indeterminate based on imaging or exam, then you get 2 points, okay? And you sum all this up, and again, if it's less than or equal to 3, you treat the patient non-operatively typically. If it's greater than or equal to 5, you typically treat that operatively. Okay, and then when you talk about thoracic spine injury, you also have to kind of talk about the Asia classification, which is the American Spinal Cord Injury Association impairment scale. And this is really helpful for the communication between providers and documentation of how severe the spinal cord injury is. And just for the review, right? A is the worst injury and E is completely normal. So when you go from E, right, to A, and the patient get worse in terms of motor and sensory dysfunction, okay? So a normal patient here is E, normal motor and sensory function. If the patient really has complete injury is group A, so no motor and sensory, right? No sacral sparing, so complete spinal injury. If they have no motor, but there's still some sensory intact, sensation intact, then it's a B, right? If 50% of the muscle less than grade 3, meaning they can't not brace their arms or legs against gravity, then that is a Asia C. And then Asia D is one that more than 50% of the muscle have a grade 3 or higher, which means they can have function, anti-gravity function, and there's a Asia D. And as we mentioned, E is completely normal. So we can take some time to go over some case example. Okay, so this is a case example 1. This is a 62-year-old male who fell from 20 feet, presenting with Carrillo syndrome. So you can tell that this is a relatively young gentleman with a very high engine mechanism falling from 20 feet, right? Otherwise, relatively healthy. But you already know that the neurologic status is Carrillo syndrome. So this is a very serious condition that should probably be addressed sooner than later. Here are the sagittal and axial CT, and as well as MRI scan. On the CT, you can see an L3 injury, and you would classify this as a burst fracture, right? Because there is compression of the anterior column, compression of the middle column, right? And you also see there's a lot of retropulsion of the bony fragment. And on the MRI scan, you can also see that there, again, this compression of the anterior column, middle column. Here, the spinal, the cauda equina is really compressed. Okay, as you can see here, here's the cauda equina here. Here's the bony fragment here. You can see a little bit of a laminar split here or a fracture here. And when you look at the PLC complex, remember it consists of 4 structures, right? The ligament flavum, right? The facet capsule, interspinous ligament, supraspinous ligament. This really looks intact, okay? So how would we grade this or classify this based on the TLICS score? So we know that it's a burst fracture, so that's 2 points. The patient has cauda equina, which is 3 points, so that's already 5. And the integrity of the PLC is intact, so the patient has a score of 5. Again, 5 or greater, we generally recommend surgery, especially when the patient has cauda equina syndrome. So we actually took the patient that night and did a posterior decompression from L2 here to L4, right? We actually tamped down the bony, retropulsed bony fragment and then instrument across that. So we did a short segment fusion for this patient and he regained some bowel and bladder function, not completely normal, but you can see that his motor function is completely fine and he's getting standing upright, x-ray here, and everything looks relatively stable, okay? So that was a TLICS score of 5. Let's do another example. So this is a 62-year-old male hit by a tree branch, complete spinal cord injury below T5. So this was one that I recently did. Let me see if I have any more imaging. Nope, no more imaging. So this you can see is an injury at the T5. I believe is a T6, 7 here. So this is T6 here. This is T7, so it's a T6, 7 fracture dislocation. Here, there is some compression deformity of the T7. There's some also bony fragment, but the T6 is completely dislocated from T7. And in fact, there's a lot of posterior bony element fracture. And right here, the facet is no longer intact. So already, we can kind of get a sense that this is a very major injury. And the patient is also a complete spinal cord injury, okay, the thoracic spine. So by calculation, this is a translational or rotational injury, so 3 points. The patient has complete spinal cord injury, so that's 2 points. That's already 5, right? So even by that alone, that require some kind of surgical intervention. And the PLC is injured, as you can tell from the posterior, from the CT. So this patient has a score of 8. And so again, we also take the patient to the operating room late that night, decompress the spine, and you can see that we did a nice job reducing that T6 on T7 fracture dislocation. Okay, so now it's completely aligned, although it's still compressed. And then we instrument from 2 levels above and 2 levels below the level of the injury. Unfortunately, he has not regained much function of his lower extremity yet. And in fact, when we went there intraoperatively, we saw that this cord was partially transected. So the chance of any recovery is very slim. All right, finally, maybe a tougher case here to really diagnose is, next one, is a 36-year-old female motor vehicle accident presented with just back pain, neurologically intact, okay? So as you see, here's the spine, and if you look at the radiology report, they would say, hey, look, there's some compression fracture of L3 and L2, right? Just anterior column only, you can see that. Okay, but the radiology report did not record anything else, right? There was no other mention of any other injury, and all you have is a CT scan, right? So you have to be careful. It's not every compression fracture is really a compression fracture. You also have to make sure that it's not actually a flexion distraction injury. So you got to follow the facet. You look at the facet in the back, and here's the facet is narrow, and you can see the facet is a little bit wide here, and then the facet get narrow again. Similarly, on the contralateral side here, facet is narrow below, but at that level here, the facet are wide, right? So there is a distraction component here in the posterior column, okay? So how you calculate this is actually a flexion distraction injury, right? You get a 4. The patient is intact, so you get a 0. But you know, the PLC is completely out because of the distraction injury, so it's injured. So it's a 7, right? So this is a score of 7. And we did a very small surgery. We just decompressed at that level and then instrument at that level, which is at that L2, L3 level, and did a small segment, short segment fusion. And the patient did very well after surgery. So you know it's an unstable spine injury. Okay, that was the end of the talk there. If you have any questions or concerns, please feel free to email me or contact me, okay? And I'll be able to share some of the PDF PowerPoint, this PowerPoint, as well as the PDF on the different type of thoracolumbar spine anatomy classification.